Evening, everyone. We're just getting ready to go live in about 6 minutes or so. So if people are on and can hear me, if people can just shout out and let me know that they can hear me okay, or let me know if there's any issues that they're aware of. Otherwise, grab yourself a cup of tea and or a glass of water, and we'll get underway shortly. Greetings to India. Greetings. Hope you can hear me okay. We've got about 5 minutes until we're scheduled to start, but thanks for joining in. Hopefully there's some good information for you to learn, and if you know some things, please share them with us. Great. Okay. Thank you. Okay, we're international. Hi from England. Hello, England. How are you? You've had a budget today or yesterday? Yeah, that's a little bit off topic, but I'm sure that's your big news. All right, just a few moments to go, and we will get started. I've got a few questions to get through, so in just a moment we'll get those cracking. Let's see indeed. Let's see indeed how that goes. Best of luck with that one. Best of luck. Sure. No problem. I've got some questions from our members to go through. I've got some questions about prostate cancer. I've got some questions to go through about BPH and urinary symptoms related to big prostates. So I'll go through those. Any preference? Where do people want me to? Good evening. Good evening. Any preference? Do people want me to start with prostate cancer or urinary symptoms? There, hit me with the answer, and I'll roll with whatever I get first. We've still got here GMT plus 10, and we've got 2 minutes just to give people time to get on board, and then we'll get cracking with the questions. And urinary symptoms. Okay, there it is. We're going to start with some BPH or benign prostatic hyperplasia type questions this evening, and then we'll get into prostate cancer. Okay, so keep coming with the discussion. I'm going to start things. I've got a minute to go, and then we're going to get going with some BPH questions. I'm going to start this evening with a question that I have from a gentleman in Melbourne. So if we have Steve, hopefully Steve from Melbourne is watching. I'm going to give him a few more seconds. It's almost 7:30 here, and once the clock ticks over, I'll get cracking. But Steve from Melbourne had a question for us. He's had some urinary symptoms that have been causing him some bother for some time. Let me start out by saying that the information that I give tonight, this is going to be a general overview with regards the key principles of how we manage different issues, whether it's prostate cancer or BPH or urinary issues related to a big prostate. I'm going to give you an overview. I cannot give specific personalized advice in this setting. I don't know you. I don't know your specific situation. So what I say this evening is very much a guide. So please do not take it as absolute, but I can talk in general principles and let you know across the board how we manage specific situations, the pros and cons, if you like, of a nuanced situation. Okay, so Steve Steve from Melbourne has put forward a question to me. Typical scenario that I see at the prostate clinic all the time. This man, he's had urinary issues for around 10 years. His main issue is frequency and nocturia. So frequency, going to pee lots through the day, nocturia, getting up multiple times at night to go and pee. Clearly, he is tired and exhausted and wants some remedy. Now, this gentleman has been screened or worked up for prostate cancer, and you know that the way that we go through that, men have a PSA test. If there are abnormalities to the PSA test, a man is then offered an MRI scan, and the MRI scan really is the cornerstone of prostate cancer screening. The accuracy, if you like, of an MRI scan is around 90%. So the false negative rate, i.e. the probability that someone can still have prostate cancer with a normal MRI scan, is around 10%. So it's not absolute, it's not a guarantee, but it's pretty close for a non-invasive test to give us a really good handle on whether or not someone is likely to have prostate cancer. So the gentleman that I'm talking about, he's had an MRI scan that did show that, interestingly enough, he didn't have a huge prostate. So to give you an idea about prostate volume, the average size is around 30 mils or 30 cc's. And we can see prostates that increase up to 2, 3, rarely 400 mils in size. But, anything over around 35 is considered enlarged. And obviously it increases from there. Now, This gentleman had a prostate volume of around 30 cc's. He's had a flexible cystoscopy, which is a camera test to have a look at the plumbing, basically to try and work out the shape and configuration of someone's prostate with a view to determining which treatments are suitable for a man. Now, he's been offered a TURP. Many of you may be aware the TURP, if you like, is the standard or the traditional way to manage urinary issues related to prostatic enlargement. It's done in different ways, but in essence, it uses electricity passed through a wire, and that wire is then pulled through the internal aspect of the prostate to remove overgrown obstructing tissue to unblock the bladder. It's been around for a long period of time. It is effective, very effective, in fact, at unblocking a prostate. The challenges that we have with a TURP is the risk of bleeding afterwards that can on occasions require a blood transfusion if that bleeding is significant. And there are sexual side effects associated with that procedure, which do include ejaculatory changes where men have retrograde ejaculation or actually don't emit any fluid at all. And some men, up to around 20% of men following a TURP, can actually experience erectile dysfunction. So effective treatment at unobstructing a bladder, but it's not without its potential side effects. And that really is what drives many men to look for alternatives to the TURP. And those men are looking for an alternative that can improve their function but cause fewer sexual side effects. So that really has been the driver for looking at things like a laser prostatectomy, whether that's a HOLEP or a green light. But we've also got more minimally invasive treatments, and they include things like iTind, they include things like Resume, or alternatively Urolift. And the suitability of those treatments really depends upon as I say, the shape of someone's prostate. So when we're dealing with smaller prostates like this gentleman that put in the question, without actually having seen what it looks like inside his prostate, but if he's got a prostate that volume that's around 30 cc's, he could be a candidate for any one of those three more minimally invasive treatments. If the obstruction, and this is an important point to be aware of, if the obstruction is at the bladder neck, which is the junction between the bladder and the prostate, and sometimes we can see that the muscle in that area can become hypertrophied, or it can become more developed, and it can actually cause an obstruction without someone having a big prostate, then one of the ways that we can manage this is with a treatment which is called a bladder neck incision, where we divide that muscle and we insert Urolift clips to hold open the sides of that bladder neck. Now that can be a very effective treatment at unobstructing the bladder. There is next to zero risk to erections, and the risk of retrograde ejaculation is pretty minimal. It's around 10, potentially 15%, depending on how the bladder neck incision is actually done. So for very small prostates, that can be a good treatment. The alternative is Resume, where we inject steam into the prostate, and the alternative is a newer treatment, which is iTind. And some of you may have heard about this, but iTind in essence is a procedure whereby we insert an expanding metallic basket inside the prostate, and what happens is that three-pronged basket in essence opens gradually across the course of around 7 days, and that creates an opening or a channel inside the prostate. The basket is subsequently removed, but the vision is that the pressure that is created by that expanding basket creates scar tissue internally that holds and keeps the channel inside the prostate open and unobstructs a man and gives him a stronger urinary stream. So to kind of summarize, if someone's got bothersome urinary symptoms, And I say this to all men I see at the prostate clinic day by day, but the way that we manage urinary symptoms really depends on how annoying you find it. If it's not annoying for you, you don't need to have treatment beyond us going through the process of making sure that you don't have prostate cancer. If it is annoying, then we escalate treatment beyond where you currently are. We look at lifestyle modification, so look at how much fluid you drink, how much caffeine you take on board, and if you consume alcohol, and the relationship that the consumption of those things can have on the way that you pee. So beyond lifestyle factors, the next step really is to consider medication. And medication takes on two different forms. And this kind of segues into the next question that I had. And that was, whilst we're on the subject of urinary issues, I'll segue into this. And please, if people have got questions about what I'm talking about right now on the urinary issue side of things, please put your questions in the chat pertaining to this bigger question that I'm going through at the moment. So a question that I had wanted me to compare and contrast, if you like, the different medications that we have for BPH. So though the two key classes of drug that we have, number one is an alpha blocker. And in Australia, an alpha blocker really involves something called tamsulosin, silodosin, or minipress. So these are the common alpha blockers that we see. The alternative is a 5-alpha reductase inhibitor. And examples of that are finasteride or dutasteride. Here in Australia, there is a combination tablet whereby there is some tamsulosin and there is some dutasteride. And I'll get into that in a little bit. So alpha blockers really are the entry-level medication to manage men's urinary issues. Effectively, they are smooth muscle relaxants. Depending on the drug, you can take 1 tablet a day. The alternative is something like minipress, which is titratable, and you can take a tablet in the evening, in the morning, and you increase that until you get the benefit that you're looking for, or potentially any side effect from the medication. Alpha blockers, as I say, they relax the prostate, and the vision when you take it is that you get a stronger flow and ultimately you go less often to pee. The downside is it's a tablet that you have to take regularly, and the potential side effects, the common side effects with alpha blockers, number one is postural hypotension. Basically what that means is that you can feel a bit lightheaded or a bit dizzy when you go from sitting to standing. The other possibility is that men develop something called rhinitis, which is where you feel like you've got a bit of a stuffy nose or a bit of a head cold. For the majority of men, those side effects are pretty mild. Rarely they can be extreme, but for the majority of people, they're quite mild, and men tend to adapt to them when they have taken them for a longer period of time. In younger men, alpha blockers can result in retrograde ejaculation. So that's the situation where you have an orgasm and you don't emit fluid out the end of your penis. In fact, it goes backwards into your bladder. And some men find that situation weird and they don't like taking the medication because of that. So, you know, horses for courses, you obviously decide on how you'd like to manage your situation if you are dealing with urinary issues. The 5-alpha reductase inhibitors, they are drugs that basically prevent testosterone being converted to its active metabolite. And as a byproduct of that, there's a lower level of that active metabolite, particularly in the prostate. Tamsulosin works pretty much immediately, whereas finasteride or dutasteride takes time to exert its effects. And to get the maximum benefit from it, you really need to be on it for 6 months plus. So it gradually shrinks the prostate with time. And if someone's been on dutasteride or finasteride for 6 months plus, we can see a 20+% reduction in the size of their prostate. It's important to be aware when people take 5-alpha reductase inhibitors, if you've been on that for 6 months or more, it will actually reduce your PSA by 50%. So, for example, you may have a PSA of 3, you get put on dutasteride, you have your annual PSA, and a year later, that PSA should be down to 1.5 or thereabouts. If a PSA increases while someone is taking a 5-alpha reductase inhibitor, that's a bit of a red flag with regards to the potential for that person having prostate cancer. And so a PSA level when someone's on a 5-alpha reductase inhibitor becomes more specific for the potential of a prostate cancer diagnosis. Now, on a quick aside, thanks for the questions coming in. I will get to those. Let me just wrap up the BPH segment at the moment. Here on Australia, there is a tablet. One brand is called Duodart and the other one's called Doublets. It's basically a combination tablet that contains some tamsulosin, some dutasteride in it. And here, one of the advantages of that tablet is basically that it's on the PBS. So it costs the price of a script, which is around $7. Tamsulosin is not on the PBS, and so you have to pay out of pocket for that. And it can cost men around $40 to $50 per month, depending on where you source your medication, for that drug. So many family doctors, many GPs actually, their starting point is this drug, this combination tablet of Duodart or Doublets. Really important to be aware, though, that one of the potential side effects of a 5-alpha reductase inhibitor is that it can reduce a man's libido and can worsen or precipitate erectile changes for the worse, not for the better. And so in my practice, the use of a 5-alpha reductase inhibitor is limited to those men who have big prostates, so over 40 cc's in size, and they're not really interested in sexual function. I don't give 5-alpha reductase inhibitors to men in my practice if they're younger, if they're still sexually active, if it's still important for them, then I steer them away from that drug, because the potential is that we could make your sexual function worse. So it's kind of horses for courses. So if you're someone out there who's got urinary issues that cause you some bother, and you're looking at medical options, I would steer you towards an alpha blocker to begin with. If you're sexually active, if you're not sexually active, your prostate's big and you want treatment, then combination therapy is going to be better. So combination therapy with tamsulosin and also dutasteride is a better combination if you've got a bigger prostate, but it comes at a price, and it's important that you're aware of that potential. Okay, that's my kind of BPH question. I hope that answers that for Steve down in Melbourne. I hope that answers your question. Will, good evening. Hope you're well. Welcome to the live chat. Your question is, you had a robot-assisted prostatectomy on November 10. You still have the catheter in. What's today? Today is the 27th. Okay, Steve, excellent. So you still got the catheter in and you've got some blood in your urine. Is that normal? Yeah, look, long story short, the answer to that is yes. Look, lots different urologists manage people post-operatively in different ways. So to give you an idea, firstly, the robotic assisted radical prostatectomy is and I'm presuming in your question, there's two types of robotic assisted prostatectomy. One is a simple and the other one is a radical. A simple prostatectomy is a treatment that we do for men who have massive BPH. So men who have very big prostates, have got bothersome urinary symptoms, and the prostate really is too big for us to manage internally. So those people have a robotic simple where they keep their prostate, but they keep only the shell or the outer part of the prostate. And what we do basically is to enucleate or remove the entire middle part of the prostate. So we remove the entire middle part, we bring the lining of the bladder down internally inside the prostate, and those men have a catheter. In my practice, I usually leave the catheter in for a week, and then we take the catheter out. Sometimes if men have bladder dysfunction of some degree, so if they're retaining a lot of urine and it's very hard for them to pee, and we think their bladder needs an additional period of rest, we may leave the catheter in. We may leave the catheter in for 2 weeks to let it to rest. Okay, pros and cons of a catheter. Look, everyone hates having a catheter in for obvious reasons. It irritates where it comes out of the urethra. It can rub up on the lining of the bladder. It's not uncommon for men to see blood actually through the middle of the catheter or around the outside of the catheter. At the other end of the catheter is a balloon, and in that balloon can be anywhere between 30 to sometimes 40 mils of fluid. And that balloon, so it's basically the size of a golf ball, and that balloon can rub up on the lining of the bladder, can cause irritation and spasm, and that can make men feel like they need to pee, but they get bypassing. So urine can skirt round about the catheter as well as going through the middle of the catheter itself. All of that stuff is completely normal. If someone has a robotic radical prostatectomy, i.e. we take the whole prostate away, and then we've got the bladder and the urethra, and we join the two together, we leave the catheter in place. Again, usually at the prostate clinic, it's left in for a week. I do a cystogram, which is a dye test at a week to make sure the joint has sealed. In just about everyone, it seals at a week. A small proportion of people, it takes another week to seal, and then we take the catheter out. So yes, with that procedure, a robotic radical, it's not uncommon to see blood in your urine or around the outside of the catheter. Again, the key really is hydration, and I advise all of my men keep drinking plenty of water and walk. So beyond not liking the catheter, the other thing that men really don't like after that procedure is that their bowel function can be a little bit sluggish, and it can take anywhere from a day to 5 days for their bowels to open. So my general advice is hydration. Try and keep the urine in the bag looking as clear as possible, and walk. You know, I encourage my men to walk a minimum of half a K the day after their surgery, and then walk a minimum of a K every day until we take the catheter out. You get outside, you see some sunlight, you feel a bit more human, you get your bowel function going, you reduce your risk of developing clots in your legs. So all of that is incredibly beneficial. William, I hope that can you let me know? I hope that answers your question. And okay, we've got Anupam. Welcome to the live chat from India. I've got some questions. I'll jump into your questions. Your question, okay, interesting question. So your question was, does taking a proton pump inhibitor, so for those people that don't know, a PPI or a proton pump inhibitor is a class of medication that people take if they've got reflux issues, so gastroesophageal reflux disease, GORD, which basically means that you have issues with acid reflux from your stomach into the gullet, into the esophagus. And one of the ways to treat that is by taking a medication which can reduce your acid level, basically. Question is, does taking that cause BPH or prostate enlargement, one in the same, or cancer in the long run? Short answer is no. So the reason why men develop BPH really is the cumulative exposure to testosterone. So, you know, you hit puberty at 12, 13, 14, testosterone levels go up, they remain up really until we are in our latter years in life, and then they can dwindle down. But it's the cumulative exposure to testosterone. So men have it in their system for 50, 60, 70 years, and it's that is the main driver for why we get BPH. BPH is benign prostatic hyperplasia, where there are more cells in the middle part of the prostate. It grows bigger, and that's why we end up with obstructive urinary symptoms, and ultimately they can progress to irritative symptoms when we see bladder changes. So it's not a byproduct of PPI. Anupam, I hope that answers your question. You had a follow-up. So again, I'm going to answer your question generically. Again, I cannot give specific advice because I don't know people's individual situations. However, your question basically is related to, is it possible that someone can have a PI-RAD5 on an MRI scan and for this to be prostatitis and not cancer? And the short answer to that is yes, it is possible. So if I take a step back, the MRI scan, as I said, is our diagnostic tool for working out someone's risk of having prostate cancer. And we grade the scans from 1 to 5. 1 is plumb normal, low probability of cancer. 5 looks really abnormal. And the difference between a 4 and a 5 really is the size of the spot, and the 5 is obviously larger than a 4. And the correlation, and there's center variation with this. So it depends on the expertise of someone reporting the MRI scan, how many MRI scans are reviewed by that particular radiologist regularly, and that predicts, if you like, in part the accuracy of the reporting. But do we or can we see PI-RAD5s in people if they've had, for example, a bout of acute bacterial prostatitis? The answer is yes, we can. And that's very possible. And that is why it's always critical to get someone's history. So people who have florid prostatitis, bacterial prostatitis, they normally come into hospital and they're really unwell. So they have high temperatures, they have a lot of pain, and they struggle to pee. And those men require antibiotics to get everything settled down, and that can be a situation whereby we can have a false positive PSA, and so if someone has an MRI scan, we can get a false positive MRI scan, and they can have a PI-RAD5. Okay, let me have a look. Okay, William, I answered your question. That's great. Now, I've got another question. I've got an interesting question here that, okay, great, Anupam. So I've had a question related to penile shortening after a radical prostatectomy. So penile shortening after a radical prostatectomy. And a gentleman has asked me, his specific question was, and Mike, and so Mike, if you're out there, Mike, this is your question. His question related to during the procedure, and I'm assuming the procedure he's referring to is a radical prostatectomy, but the question is, why can't the prostate, if you like, be dissected, and the urethra, which is the outlet pipe of the bladder, why can't the prostate be dissected off the urethra left intact, and then the prostate tissue taken away? And would this, if we did do this, would this hi Mike, okay, so this is your question, would this result in less penile shortening? Okay, so if I back up on that, so conceptually, the prostate is shaped like a donut. It sits underneath the bladder, and the outlet pipe, or the urethra, basically goes through the middle. And so I describe it like a donut because the best way to think about it is that the prostatic urethra, which is the outlet pipe as it goes through the prostate, and the prostate are basically one in the same. So they're the same. Now, is it possible? Has it been described before to do exactly as you've suggested, Mike, where we basically, if it's cut down the front, peel the prostate away, leave the tube, and then we don't have problems with penile shortening? Well, it has been done, but the challenges with that are prostate cancer, number one, tends to be multifocal. It tends to be multifocal, meaning it's in different areas of the prostate. And the minute you start cutting into the prostate, we run the risk of cutting into cancer and potentially facilitating cancer cells to escape. And many men actually ask me about what's the possibility of doing, if you like, a partial prostatectomy. So if on MRI and on PET scan we only see one spot, can we just cut that spot out and stitch the rest of the prostate up? The challenge is the prostate has got a great blood supply, and doing cutting a piece off, A, is inaccurate, B, runs the risk of dissemination of cancer cells from cutting into the cancer, and C, it would be a bloody operation with greater blood loss and potentially disruption to the urethra. Now, if you peel away the whole prostate and you leave just the tube, basically what you've done is you've removed the blood supply for that tube. And that tube is then very prone to scarring. And you have a segment or a length of tube. You have a length of tube connecting bladder to the urethra from the pelvic floor that can be scarred. And when it's scarred, it contracts and you have obstruction. And that can be very difficult in itself to treat. Now, penile shortening is not necessarily uncommon after surgery. And the reason why men can develop penile shortening is because of a change in blood supply. Yeah, okay, Mike, yeah. So it's a change in blood supply. So depending on your quality of erections when you go into surgery, after surgery, if we're able to do a bilateral nerve spare, even when we do that, still for the majority of men, erections go after surgery, and it takes a period of time for us to recover those erections. And that period of time, it can be a year to a year and a half for men to recover their erectile function. And during that time, we give men PDE5 inhibitors, so things like sildenafil, Viagra, tadalafil, Cialis, because we're trying to maintain perfusion. But it is a change in perfusion that causes shortening. So it's a blood flow phenomenon that causes shortening. And the way I describe it to men is like the erectile tissue in the penis, it's a bit like a sponge. If there's no fluid going in, the spongy tissue dries up and it shortens. And that's why, if men are interested in sexual function recovery after surgery, it's critical that they go through a penile rehab type process where you take PD5 inhibitors and you try to be sexually active. You try to have stimulation to maximize blood supply to your penis, to maintain a healthy penis and penile length, so that when you do recover at that 12-18 month mark, the quality of recovery that we get is far better than if we do nothing. Okay, Mike, Mike, just clarify for me if that covers your question, if that has answered that adequately for you. Let me know. Okay, I have a question now from okay, well, that's good. So that was the conversation that I had with Dr. Jackson. So we've got a comment from Mike there about a previous video that we did where Dr. Jackson and I, who's a radiation oncologist, we had a discussion about the pros and cons of surgery versus radiotherapy to manage localized prostate cancer, you know, the limitations with each of those and which man really is ideally suited for radiotherapy and who might be better off suited with surgery. And, you know, one size doesn't fit all. And, you know, everyone's disease profile is different. Everyone's prostate is different. Everyone's overall health is different. You know, one thing that we did say in that conversation was that as men progress through life, you know, surgery, the older you get, and by that I mean kind of if you're over 75, the challenges with surgery really are the probability of longer term incontinence. The pelvic floor, which really is the nuts and bolts of what keeps us dry, doesn't recover as well after surgery as it does in men that are younger. And so really, if someone has got significant disease, significant prostate cancer, they're over the age of 75, really they are, you know, they're in my opinion, they're better managed with radiation treatment. There's no different in 10-year cancer-specific outcomes. We cure, you know, the same number of people, and the probability that someone, you know, bounces back quicker after radiotherapy is higher than surgery in my opinion. But obviously there are nuances to everyone's situation, and that's just an overview. Diathermy action of the procedure, of the diathermy of the surgery, I presume, might kill any adjacent. So it depends. It depends where someone's cancer is. So we don't use diathermy, for example, when we're really close to the urethra, and we don't use electrical energy, and we don't use diathermy when we're close to the neurovascular bundle, because diathermy is heat, and heat can cause issue to certain structures. Okay, question from Rodney. If you're... Anupan, let me get to that in a second. I just want to touch on a question from Rodney. So Rodney posed a question to me. His question was related to the success of salvage treatment, with 6 months of ADT, with 6 months of hormone therapy. So this question is, if someone has had a radical prostatectomy, they've had their prostate removed, and they have recurrent cancer, what is the probability of success if we give them salvage therapy? So if we give them another treatment, and salvage therapy after surgery is radiation, and that can be given, with hormone therapy. So the success really, like everything, it boils down ultimately to the blueprint of someone's cancer. And what I mean by that is, you have your prostate removed, we send the prostate off to the lab, and the lab basically look at the entire prostate, and the question that they're asking, what's the final Gleason score? How big is the cancer? Is it contained? Is there any extension of the cancer to the shell? Is there extension of the cancer into the seminal vesicles, of which there are 2 that are at the base of the prostate? There are also finer print details, if you like, looking at, is there lymphovascular invasion? Is there invasion into the lymphatic channels, into vascular spaces? Is there perineural invasion, i.e. is there invasion roundabout small nerves in the prostate? All of this basically gives us a profile of someone's cancer. What's the probability that we've cured their cancer with surgery on its own? What's the probability of local recurrence? And what's the probability of what we call micrometastatic recurrence? Local recurrence, i.e. cancer cells coming back or being persistently present in the area where someone's prostate used to be, is increased if someone has disease that has grown to the shell, if there is cancer at the edge, and if there is extension into the seminal vesicle. If someone has those characteristics and they have a change in their PSA, then that man needs a discussion about salvage radiotherapy. Now, some men can have those features, but they can also have features that increase the risk that there could be recurrence in a micrometastatic fashion, meaning that there could be a small little cancer cell that has already skipped and gone elsewhere, and that could be to pelvic lymph nodes, it could be further afield. Now, the men that are at a greater risk of that happening are those men who have higher grade cancer. So those men, for example, that have a Gleason 4 + 4 = 8, so a grade 4 cancer, or anyone who has pattern 5 on their final lab test. If someone has cancer that is a big tumor that's through the shell and it's a Gleason 9, well, that man has got a risk that he can develop recurrent cancer in the prostate and also micrometastatic disease elsewhere. So the question was, what's the success rate of having salvage radiotherapy? And the answer is, it depends. And it depends very much on what your disease profile was. So, for example, if someone has a Gleason 7 tumor, so a 3 + 4 = 7, they've got a grade 2 cancer. If there's cancer through the shell, but they've got a clear margin, and that man's PSA goes up, usually that PSA will go up very slowly, and it can take years before it gets to a threshold at which point we think we need to treat. That man, if he has salvage radiotherapy on its own, is very likely, so he's got a high chance that that additional radiotherapy, that salvage treatment, is going to affect cure, and that there is a lower probability of recurrence beyond that. If someone has a Gleason 9, a 4 + 5 = 9, it's a big cancer, it's through the shell, there's cancer at the edge, that man, again, he needs to have salvage radiotherapy if his PSA is going up after treatment. And whilst we have a high success rate of controlling the pelvis, he still is at risk of recurrence outside of the pelvis elsewhere that has not been treated. And that's the micrometastatic component. Now, the utility of adding in hormone therapy is an area that, is getting a lot of attention currently. And that is both in the primary setting. So if someone is choosing to have radiation treatment as their primary therapy instead of having surgery, historically, we used to give anyone really with intermediate risk disease, so Gleason 7, a 3 + 4 or a 4 + 3, we would give those men what was called neoadjuvant ADT. So we'd give them hormone therapy up front for 6 months. Then we started exploring with higher grade cancers and those men having hormone therapy up to 2 or 3 years beyond the time that they had radiotherapy. So, a huge range of time. The challenge with hormone therapy is it's not without side effects. And, many men get hot flushes, they feel lousy, they don't have a lot of energy, their libido and sexual function goes, they put on weight. Some men describe a bit of brain fog. So, for many men, it can be an unpleasant process to go through. Nowadays we are far more selective about who does have hormone therapy. And if men have favorable grade 2 cancer, we don't really use it. If men have more adverse characteristics, such as a larger volume 437, we might give ADT. Certainly if people have a Gleason 8 or a 9 or a 10, hormone therapy is without doubt a cornerstone that we use in conjunction with radiation, certainly in a primary setting, but also in a salvage setting. Crudely speaking, the more aggressive someone's features are, the more we use combination of treatments. And if someone has recurrence and they've got higher grade disease, that salvage radiotherapy is often combined with hormone therapy. Rodney, I hope that answers your question. If you're watching, Rodney, give me some feedback if possible. Let me know if that answers your question, or if you have a follow-up on that. Okay. Okay, quick question there about spreading cancer cells during a biopsy. You know, it's an interesting one. Anupam, we made a video on that from July of this year. If you want to go back and have a look at that video, I addressed that question. You know, it's a really interesting question. I kind of get, you know, I get it intuitively, the concept that if you go and put a needle in something, that there's the potential to shed cancer cells along that needle pathway. I understand the kind of the logic of that. You know, my answer to that question, though, is that not all cancers recur, and the probability of recurrence is related to the biology of the tumor itself. And crudely speaking, that relates to the Gleason score. And what I mean by that, for example, is if you've got a Gleason 336, so you've got a grade 1 cancer, those cancers, they never spread. They don't cause a problem. They shouldn't be treated. The difference between a Gleason 6 cancer and a high-grade cancer is the ability of high-grade cancers to invade around nerves, to invade lymphatic channels, to invade blood vessels, and to get through the shell of the prostate. So high-grade cancers have in their DNA the blueprint to be able to metastasize, i.e. to spread, and that's driven by the intrinsic behavior of the cancer cells themselves. So my opinion is that it's the biology of the tumor that facilitates spread, not the biopsy process itself. Now, there is, for obvious reasons, there is interest in trying to work out if we can ever shift to a situation whereby the reliability of non-invasive diagnostic tools is good enough such that men don't need to have a biopsy, and we can be confident on the basis of imaging alone to proceed on with definitive therapy. And there have been some publications looking at that, you know, looking at a combination of both MRI and PET scan and making a decision. Thanks, Mike. And then making a decision based upon those two criteria alone. We're certainly not at that point, nowhere near that point at this stage. I think it's definitely worth studying. It's definitely worth doing in a trial setting to get a conclusive answer on that before we shift our practice. The concern obviously would be, you know, no test is 100% accurate. And if we get it wrong and someone has a prostatectomy and they don't have cancer, well, that's a disaster. So that's certainly not what we're looking for. Okay, that was pretty good. I think we covered some stuff. We're almost, thanks, Anupam. You know, we covered some stuff this evening. We're at about an hour. Any final thoughts? I'm not looking for curly questions, but any final thoughts before we wrap up this evening's Q&A? Members, please, if you want a copy of the transcript for tonight, please, can you email the office? I'll put the email. If you email the office, we will get a transcript of tonight's discussion out to you guys, so you have it for your reference. You know what we've discussed this evening. As always, you know, if you okay, you got in, Gig, you got in the last one there. Let me just, Okay. Quick question was related to erectile function following radiation treatment. Thank you, John. Thank you, John. I'll answer this one, and then we'll call it a night. But basically, erectile dysfunction following radiation treatment. So, if you have surgery, changes happen immediately, and then men recover afterwards. If you have radiotherapy, radiotherapy tends to work more slowly, more gradually, more progressively. So the majority of men, certainly in Australia now, the standard way that radiation is given is in a dose escalation fashion, which means that we give fewer doses that are a little bit bigger than they used to be. So men used to have 7 weeks of treatment that was 5 days per week. Now the standard really is 5 days a week for 4 weeks. So we give men 20 fractions instead of 35. Again, the potential for erectile changes is going to be influenced not only by the treatment itself, but by the quality of sexual function leading into the treatment itself. So, how good are someone's erections before they have radiotherapy? Are they waking up in the morning with erections? And how frequently are they sexually active? We also need to be mindful of the metabolic risk factors that increase the risk of erectile dysfunction as we progress through life. So, for example, type 2 diabetes, high blood pressure, high cholesterol, carrying too much weight, an elevated BMI, if men are a smoker or if they've had surgery of some descript in the area. All of those things play a role. But certainly if you have hormone therapy in addition to radiation treatment, then it really reduces the probability of recovery. That being said, what can you do if you wish to explore sexual function recovery following radiotherapy? Well, there's kind of two aspects to this. Number one is basically trying to be as fit and as healthy as we can be. Look at what we eat. And from an activity point of view, I advise all my patients, number one, lift weights. Get in the gym, lift weights. If you don't know how to do it, get yourself a PT or get someone at your local gym to teach you how to lift weights in a safe way. If you've never done it beforehand, don't just pick up weights and hurt your back, but do it under guidance. We should all be lifting weights. It reduces the probability of sarcopenia, which is muscle loss. It improves our body's ability to regulate sugar. It really also helps with cancer-specific recovery and reduces the probability of recurrence if you're fit and active and you lift weights. So cornerstone, being fit and healthy, lift weights. What you can do specifically is take PDE5 inhibitors. So you can take drugs like Viagra or alternatively Cialis. So that's tadalafil and sildenafil. If that doesn't work, the next option that you have are penile injections. And the next option that you have beyond that is a penile prosthesis, which basically is a surgical device, an inflatable device that is inserted that allows you to have a controllable erection for as long or as short as you want. Pros and cons of that. The pro is it definitively fixes the problem. And these implants today last for 15 years. The downside is it's an operation to get the implant in. There is a risk of infection. It's about 1% if you don't have diabetes. If you do, it's about 3 or 4%. That's pretty much what we've got. All she wrote. Okay, guys, I think that's about enough for me. I've spoken for an hour. Thank you for your interaction. Some great questions tonight. I enjoyed that. I hope it was informative for you. If you want to join us the last Thursday of every month, 7:30 p.m. GMT plus 10, so Brisbane time, we'll be doing this. Join the channel, please. Get your questions in and take care of your prostate.